We are super excited and really appreciative that Robin Gelburd, president of Fair Health, has come out from New York to be with us. Fair Health does a lot of interesting things that she will tell us about. I mentioned the pricing data earlier. They also have a lot of clinical data that I think we're going to find super interesting. And so without further ado, let's give her a round of applause. Put your backs into it for Robin, please. Thanks, Robin. Come on up.
Thank you, DJ. It is such a pleasure to be here among such a diverse and engaged group of stakeholders. Really thrilling, and having listened to so many of the conversations over the course of the conference, I feel like it's like hot off of the presses, a lot of issues that are being discussed. So it's really exciting to be in the midst of that. So as DJ may have mentioned, we are a rather unusual organization. For those of you, and before, I mean, the main thing is actually to take you on a journey of our data involving Washington. But before doing that, I just want to touch a little bit on Fair Health just to contextualize our role in the healthcare market so you can better understand who we are. So we are a national, independent, not-for-profit organization created back in 2009 following an investigation by the Office of the New York Attorney General into certain perceived conflicts of interest in data that were being disseminated to help inform the adjudication of claims in other healthcare operations. It was agreed that the matter would not go to trial, that there would be a settlement, and that a new independent not-for-profit would be created that could bring integrity and transparency to healthcare and health insurance information to allow all stakeholders to exhale. Our main task really was threefold: to create a new repository of healthcare claims information that were audited, aggregated, and populate healthcare products, benchmarks, custom analytics to inform the thinking for all stakeholders. Two, as an independent 501c3 not-for-profit, we were tasked with helping government, academic researchers, policymakers really noodle through the hard questions plaguing the healthcare system today. And three, when we were handed the baton, it was to create a free consumer website that could bring visibility into healthcare pricing and insurance principles to help consumers navigate, in effect, the healthcare highway. We sit really right in the middle of that healthcare schoolyard, if you will, really working with all stakeholders and are really informed by the diverse points of view that we hear. It helps inform our work and helps us interact with all the different stakeholders and really understand the different perspectives. So what do we have? Right now, we are acknowledged to have the largest private healthcare claims collection in the country. We have over 27 billion commercial claims, that's self-insured and fully insured. Why the self-insured data is important, for those of you who follow these sort of wonkish issues, you may be aware that the Supreme Court not too long ago issued a decision coming out of Vermont regarding APCDs, and they ruled that state all-payer claims databases were prohibited from mandating the collection of self-insured data because of ERISA preemptions. We get that data voluntarily, and that helps round out the commercial market. We essentially track the healthcare experience of approximately 150 million covered lives all across the country, and that data then get organized into 493 discrete geographic regions. While we have 493 sort of individual markets across the country, which is rather granular, in Washington state there are 8 geozips, again, which tend to track with the first 3 digits of a zip code. And when you compare that to Medicare, which has 2 geographic regions, you could see the granularity of the data. And I should mention that data comes in monthly, so it's quite current and allows us to continue to refresh the data that we offer. In addition to the commercial data, because we're statistically significant in every state, CMS has designated Fair Health a national qualified entity, which means we now have been entrusted also with the entire collections of Parts A, B, and D of the Medicare data for all 58 million beneficiaries, which is another essentially a 27 billion claim collection that, again, continues to get refreshed as CMS releases its data. And so what do we do with all of this data, and how do we help inform stakeholders like yourselves? So essentially, the data are used for a variety of purposes, whether it's premium rate review, benefit design, provider network design, evaluating provider performance, looking at clinical treatment protocols, how they vary across the country, looking at trending of different diseases and different practices and pricing, informing consumer transparency platforms, populating clinical clinical trials, and also, in effect, we serve as a quasi-APCD. So what states may do is really turn to Fair Health to really understand trends within their own state, and also we allow them to look over the fence at their neighbors and see how they may compare to other states as well as nationally. And again, while we're not a government entity, we do operate in governmental space. So this map really depicts where, in terms of the purple states, shows where states have turned to Fair Health for some official use or for some educational data with respect to a healthcare program that they're trying to advance. So while we support the entire country, this is where we actually play a more formal role. And so, for example, we support a number of workers' comp fee schedules, auto liability fee schedules, dispute resolution programs, and more are playing a role in surprise billing legislation, which I know is also a topic in Washington, as it is right now in 20 other states around the country. And there's also a federal bill that has been teed up by a bipartisan group of senators. And in addition to the state work, we're a federal resource. So, for example, the Bureau of Labor Statistics has turned to Fair Health to give them a monthly data feed to help inform the preparation of their monthly CPI indices that they do for medical services. Many other agencies look to our data for some clinical guidance or trends. For example, CDC has looked to our data with respect to Lyme disease or pediatric diabetes and obesity. The Government Accountability Office has looked to our data for air ambulance pricing, which is a pain point in many states. And the USDA has been tracking our work in food allergies, and we'll be collaborating with them as well. Okay, so now let's turn to Washington. We have this ocean of claims that for many can be opaque. Our role and our goal at Fair Health is really to turn that ocean of claims into something that really brings actionable data to your doorstep. Think of it now as really taking you in a glass-bottom boat on that ocean of claims so you can see what we see and help make decisions and help understand what's happening in the ecosystem in the state. What we can do, because we have all these billions of claims, is identify trends that are occurring. In a sense, sometimes we're like the canary in the coal mine that can really bring visibility to subjects that may impact policymaking going forward. One of the areas that is really fascinating to see, and Washington is actually playing a big role in this area, there's in effect a revolution going on in where people and how people are accessing care. Non-traditional venues of care like retail clinics, ambulatory surgery centers, urgent care centers, telehealth, are starting to play a really dramatic role in the healthcare ecosystem. So I thought it would be interesting for you to see how Washington State compares to the nation in some of these areas. So let's look at retail clinic usage first. As you could see, from 2009 to 2017, Washington saw over a 3,000% increase in trend lines associated where there's a place of service on a claim depicting a retail clinic. And let me just explain how you can read these charts, because you'll see some of these going forward. What we've done here is, from 2009 to 2017, we have isolated in our repository all of those claims that have retail clinic in the place of service field where the care was rendered in a GeoZip within Washington. With that universe of claims, we then array them over the years to see what the trend lines are. Have they gone down over that time, stayed the same, and gone up? And as you can see, there's a dramatic increase. While the nation as a whole has seen an increase in retail clinics, Washington outdistances the nation. So when people present at the retail clinics, what are they presenting with? We thought it would be helpful for you to see what the main diagnoses presenting in the retail clinics are. So you could see in the #1 spot are acute respiratory infections, then urinary tract infections, and ear infections. which is different than the nation as a whole. While the number 1 spot is similar, number 2, general symptoms, is the number most frequent after acute respiratory infections nationally. And general symptoms tends to refer to malaise, headache, and fever. And then you have communicable disease exposure. And I would say that it's interesting, communicable disease exposure is not on the Washington list, because I understand you have done a pretty phenomenal job of really advancing vaccinations within the state, which would explain, one, why vaccination is number 4 in your list, and why communicable disease exposure is not on your list for retail clinics. But then looking at the age cohorts, we always like to drill down further. And as you can see, 41 to 60 is the most common age cohort accessing retail clinic care, compared to 23 to 40 nationally. And that raises some interesting questions. One, 41 to 60, you would expect to be a cohort that would be accessing a lot of vaccinations, whether it's shingles, pneumonia, flu. So that would totally make sense. On the 23 to 40, on the national level, you may ask questions whether in those other jurisdictions the primary care network is sufficiently absorbing or responsive to that population. Urgent care usage, let's turn to that. Fascinating here is that Washington is completely in lockstep with the country at 533% increase over that period of time. So again, it seems to be a venue that is growing in frequency. And again, if you look at the diagnoses, what's interesting here is the number 1, 2, 3 spot in Washington dovetails exactly with what has occurred on the retail clinic side. Again, showing that these two venues are really becoming popular primary care outposts that are allowing folks in a more convenient way to turn to care, whether it's because of the office hours or particularly if they are not having, a longstanding relationship. And as you'll see soon in terms of the age cohort, some of the younger age population are turning to these venues because they may not already have an established longstanding primary care relationship. In Washington, 31 to 40 is the more popular cohort for urgent care, whereas on the nation as a whole, it's 0 to 13, which is interesting. So the 31 to 40 may show, again, we're looking at private claims. So that means these are typically people who are employed or have private insurance. So these may be people who are working, who need some flexibility in where they are accessing care and when they are accessing care. Whereas the national 0 to 13 also use more closely to what those diagnoses are, which would be injury to the body and the general symptoms, fever. Parents, you could see bringing their younger children to those venues. Here, let's turn to ASCs, ambulatory surgery centers. This is the most recent map that has been issued by CMS with respect to the array of ASCs around the country. Washington State right now is showing 188, which ranks number 8 in the country, which is a pretty high density and penetration for the state. And when you think of Washington, which I believe is number 13 in terms of population in the country, it shows there's pretty strong coverage of ASCs in the state. Again, when you look at the trend lines from 2009 to 2017, overall, there was a 57% increase in Washington, and the nation as a whole was below that, 30%, which would make sense since Washington is in the top tier of ASC activity. There was a slight decrease in the last couple of years, and that may be because I understand there have been some auditing and surveying rules that have accelerated with respect to ASC, so there may be some remediation activities underway, or that whether that did or did not slow down the utilization, that would be an interesting data point to look under the hood of to understand that decrease. In terms of who is going most frequently to ASCs, no surprise here that it's the 51 to 60 cohort, which definitely compares on the national side as well. And that again makes sense because what happens most frequently in an ASC? endoscopies, colonoscopies, really light anesthesia, pathology, biopsies, and so forth. So it really would make sense that that would be the population most drawn to the ASCs. Emergency activity is where Washington really stands apart, and I think you really deserve a lot of credit here. Washington is one of the few states where you're seeing a bending of the curve in terms of utilization in the emergency room. While there's been over 100% increase around the country, 2014 to 17, Washington, you've actually seen a decrease in utilization. And it seems as though you've been very effective in public education campaigns in explaining to the population when it's appropriate to go to an emergency room, when there may be a step-down facility that might be more appropriate, because clearly you can see that it is unusual from the data that we're seeing to see that decrease. And also the fact that there are so many other outlets with the urgent care centers and the retail clinics, you may be seeing a siphoning off and an appropriate triage. When you look at the diagnoses in the emergency room, again, these are the top ones presenting, cardiac symptoms and cardiac events being number one, just like in the country, general symptoms being number two, with injury of the body 3. And the general symptoms in the second place, you may think, well, if that involves fever, malaise, and headache, is that more of an opportunity to triage and move those to other facilities? However, when you look at the age cohort that is utilizing the emergency room most frequently, it's exactly what you would want to see or what makes sense. In Washington, it's the over 70 population. So you can imagine when there is fever or malaise or headache in that population, which is a little bit more vulnerable, they may think it would be more prudent to go to the emergency room as opposed to some younger age cohorts. Again, I think for Washington, that really is a feather in your cap. On behavioral health usage, this has been a really interesting area to study because, as you may know, we're now coming on the 10-year anniversary of the Mental Health Parity Act. We've been asked to do a lot of analyses for different jurisdictions and stakeholders involving behavioral health to see what has happened over this 10-year period. And so what we thought would be interesting here, and it was fascinating at the lunch session to hear the concerns expressed about behavioral health in Washington, or at least as an area of focus going forward. We thought it would be interesting to compare Washington not only to the nation, but to California and Colorado, just to pick some other states to give you some perspective. And again, when you look at the trend lines over the 10 years, you could see Washington tracks lower than the others in terms of the increase. And that may be due to a number of factors. And one thing about Fair Health, we'll identify certain data points, and then it's always fascinating to dig deeper and deeper, or go down deeper into that ocean, if you will. And some researchers or policymakers take the baton from us and look deeper, and sometimes we're asked to do that as well. But in terms of that 55%, what may explain that is, one, I understand that even before the federal mental health parity law, there was a Mental Health Parity Act here in Washington. So you already were, in a sense, out of the gate, so there wasn't a use uptick. Another explanation may be, which you'll see in a moment with respect to telehealth, what we've seen nationally, behavioral health services rank highest among accessing telehealth or telemedicine. And that's something we'll turn to regarding Washington. That still seems to be a work in progress as it's evolving in Washington state, and there's not the same level of utilization, which may explain why in other states you're seeing a higher uptick there. These are the main behavioral health diagnoses from 2017, which track exactly with the national top 3 diagnoses. Mental and behavioral disorders due to substance abuse, whether it's opioid abuse or dependence, alcohol abuse, or other types of drug abuse, major depressive disorder, as well as general anxiety. Not surprising there. What is a little concerning, or something that you may want to look at further within the state of Washington, when you look at the cohorts that are really accessing behavioral health services, what's striking is that the 11 to 18-year-old age group in Washington state is the most frequent user of behavioral health services. And compared to, as you could see, the 31 to 40 nationally. And in some ways, that may resonate with some of the studies that are underway around the country with respect to really the profound sense of isolation and depression that some of those in this age group are feeling as a result of social media or online activity. We looked a little bit more closely at this age cohort to drill down further to see what are the most common diagnoses in this 11 to 18-year-old group. And what we found were depression, mood disorder, bipolar disorder, anxiety, and ADHD. So here, this is what I was alluding to before. We're only tracking national telehealth utilization here to show you the 1,500% increase from 2009 to 2017. We're not tracking Washington here because the claims are just really starting to come in. There's been some new activity within Washington, legislative activity addressing telemedicine, and we're really excited to see how that story unfolds. And as we gather more data, we're happy to update and show you what's tracking in Washington, the kinds of diagnoses that are presenting and the procedures that are being rendered, and at what cost, as we do in other states. So let's turn from those venues to pricing, because what we do at Fair Health is look at pricing through the prism in many different ways. We look at billed charges, we look at the negotiated allowed amounts, we look at it at the state level, we look at it regionally, nationally, we look at it within the state amongst geozips, and we look at rural and urban configurations just to get a flavor for what the variation is. So here, just to give you a sense, this is looking at the state level, at the 80th percentile of billed charges for a very common procedure, 99213, a typical office visit, from 2015 to 2018, just giving you a sense of how the data are arrayed to see what kinds of price increases we're seeing. Very modest, as you could see, not a high uptick in billing right there. Here, we're now looking at emergency services. Again, on the state level, these are billed charges, not the negotiated amounts, again, from 2015 to 18. And while there's some uptick, this is rather modest compared to other jurisdictions in the country. Again, both in terms of emergency services costs and your utilization, you seem to really be containing it in ways different than other states. Now, we'll look at it in a different way. Let's look at Seattle versus Washington. And what we're doing here is not just comparing Seattle to the state, but we're also comparing different reimbursement models. And we've chosen these models because these models factor in oftentimes statutes and regulations that are addressing different kinds of reimbursement programs. So the 80th percentile of charges is depicted, as well as the 50th percentile of charges. Then we're showing 125% of the median allowed amount, meaning negotiated amount, typical between plans and providers, and the CMS rate, just so you could see the hierarchy, how it is arrayed. And this is the type of data that state officials often ask for when they're trying to design a statute or regulation to understand what the implications are. And as I mentioned earlier, surprise billing right now is very current. There are over 20 states now in the midst of designing their own. New York and Connecticut have already passed theirs, and there's a federal bill pending. And here is now looking at moderate severity, again, to show you the hierarchy. And again, you could see how it differs from procedure to procedure, and it could also differ depending on what the area is. This is now looking at high or urgent severity, and you could see here where there's general parity at the 80th percentile, and where Washington State outdistances Seattle in terms of the pricing at both the 50th percentile of charges and the allowed amount, and then you can see how CMS compares. This is now taking a different view, and it's showing you at the geozip level, taking 5 geozips within the state of Washington to show you again the variation. And why this is important is it shows how the granularity helps inform different types of fee negotiations, dispute resolution programs, solutions for legislative or regulatory activity, because you could see how, in this instance, you could see how the hierarchy actually remains the same in the commercial data. And then when you look at CMS, you see how Seattle outdistances the others, whereas it doesn't outdistance the other geozips and the other categories. And that may explain why in that federal bill that right now is pending, Senator Cassidy and Senator Bennett and others, CMS has been expressly excluded, the Medicare fee schedule, as a choice for reimbursement under the federal surprise balance billing law, because there's a recognition that while Medicare plays an important role in addressing the disabled and elderly and end-stage renal disease patients, it really is a policy-based fee schedule and doesn't necessarily reflect the economic realities on the ground in the communities. This is looking at radiology. Again, I'm choosing those kinds of services that are most typically arising in the surprise out-of-network context. And again, you could see how it varies from the prior slides. It really depends on the type of specialty, the geozip, and so it's that variation that drives those really individual conversations. One area where we have felt really an important role that we could potentially play, while we give out our data to researchers to do their work, there are times when we feel it's important to really dive down ourselves into that ocean of claims and bring some visibility to a topic that's really in the public square. And obviously the opioid epidemic is one pressing concern across the country. We've done a series of free white papers. The last one, what it did was it did a 50-state review with an interactive map that's on our website, that's accessible by all. And what we tracked were the 5 most common procedures used to treat those with an opioid abuse or dependence diagnosis in a state. And then we looked at the 5 highest cost centers associated with treatments for opioid abuse and dependence. And what we learned, and while here we're only, again, comparing Washington to Colorado and California, if you looked at that 50-state tapestry, you would see enormous variation. Sometimes there are some that don't even align at all. And again, what we did here is it's color-coded if it's the same procedure, but you could see that it may be in a different hierarchy. The gray-colored procedures means that there's no match at all among the 3 states. So you could see already the variation. And what that raises is a significant issue. What is working? When we shared this opioid recent white paper with policymakers and others, the logical next question is, so what's best? Is it methadone maintenance? Is it naltrexone? Is it intensive outpatient, partial hospitalization, group therapy, individual psychotherapy, a combination of them all? No one is really studying it systematically, and it really lends itself to following cohorts in these different procedures. Here, if you look at aggregate cost, you could see that there's very little commonality. Colorado, for example, all of its 5 most costly procedures are drug tests, which leads one to think, is there something about the utilization of those drug tests? Why, is there such a dense concentration? Are those tests what should be prescribed? Is that really efficacious? Likewise, in California, you could see they very much have costs associated with partial hospitalization, intensive outpatient. Washington State has its office visits, some drug testing, but again, you could see for the most part, there's very little variation. And finally, just to leave you with just some cost indices, the Bureau of Labor Statistics had turned to Fair Health for help with their indices because we had released some free indices last March. We had been approached by a number of stakeholders who said, Fair Health, with your data, could you just play a public service and show what you're seeing in terms of year-over-year price increases? So we did that from a negotiated and a billed perspective. These are billed charges, and we organized the healthcare system into surgery, pathology, various different sections. But in the interest of time, just to give you a flavor, professional E&M, which obviously are the most common, you could see that you are tracking below the nation in terms of overall year-over-year increases, although close. And in terms of hospital and E&M, which are both evaluation and management in outpatient clinics as well as emergency, again, you are below the nation. And again, that's unusual. We often don't see the states tracking below the nation, particularly with the emergency services. So again, there's some constructive efforts underway here in the state, it appears, to really be containing your costs. Happy to take your questions.
Robin, thank you. I appreciate it. Let's have a seat.
Sure.
Let me ask you to dig deeper on the sort of retail piece and the ASC piece. You showed some data that costs and I think utilization and the ER are both down here relative to the nation, and that retail and ASC are higher. Any insights nationally among other states about why that's happening? I mean, how we might in Washington State think about what we have done here, but how do you put that kind of trend in context with other states based on the data that you've looked at?
Right, no, that's an excellent question. Nationally, we are seeing that same general revolution underway, and I think it's a recognition that there's challenges, and I think they were expressed earlier in the day about healthcare professionals and personnel and being able to staff up, really appropriately and provide proper access. I think there are access issues that are plaguing many jurisdictions, and it's a recognition that you need to let the air out of the balloon in terms of the need and the demand for these services. Also, I think there have been changes in the way people work in terms of unconventional work hours, and that there's a struggle. I know I have, sons who are now in the workforce who are frustrated about being able to leave work to get to a doctor, or really want email, want access, want convenience, want to be able to access care when they need it. And I think that explains the CVS-Aetna merger. I think there's a recognition there's going to be a whole new environment or ecosystem established with retail clinics, urgent care centers, serving as their primary care outpost as we're trying to redirect people away from the hospital, away from emergency rooms. What it does, though, is while it provides access, I think it raises the policy question of care management and care coordination. There has to be a way in which to loop back with other providers of that patient to make sure those visits are not lost, that there's continuity to care, and that there are feedback loops within the system and not duplication.
Robin, thank you for an illuminating presentation. I thought I heard you say that your organization was an outgrowth of some legal activity in New York. So I'm curious if you could say again how the source of claims data from the state of Washington, who's sending in those data to you?
Oh, excellent question. So while it was a New York investigation that started, we really became a national remedy overnight because the data company that had been disseminating data within New York had a national collection, and they were required to transfer that data to Fair Health, and that we, in effect, were able to then support the entire country. So really, overnight, we became national. Our contributors consist of national and regional payers and third-party administrators, separate from, obviously, the CMS Medicare data. So we are a national company that just had some New York roots.
Thank you. That was an excellent presentation. I love the use of hard data rather than just opinions. How do we get access to this data?
Oh, very easily. So we really believe in the democratization of data, and we try to make it available in a way that's actionable. I mean, it's incumbent upon us to transmit it in ways, whether it's visualizations, whether it's file formats, whether it is different kinds of dashboards, we make it available. Some of it, for consumers, it is free. They can go to our consumer website and access information. So on the micro level, we're trying to help Ann Smith and John Smith manage their way on that sort of healthcare highway. For other stakeholders, we work with them closely to understand what their data needs are, making sure that we're protecting the security and integrity of the data, but making it available to you in a way that allows you to advance a narrative that you're trying to share. And so you can reach out separately offline, and I'm happy to talk about that further.
And I should have asked our first two questioners to identify themselves also, name and organization.
Hi, I'm Eric Valby. I'm an actuary at Primera Blue Cross. I'm curious to know what's the future or perhaps the present of marrying health data with non-traditional, maybe lifestyle data sources. For instance, I've been using my grocery store card to keep track of my purchases and save some money, but I imagine that if I had a large database of grocery store purchases that I could match to health outcomes, I might learn something smart.
So I apologize, there's a little bit of feedback from the speaker here. Are you asking how to marry that data with other sources of data? Was that the question?
Yeah, the question is what is happening now or what could be happening soon? What's the future of going outside of just what's on the electronic medical record?
I think it was mentioned at the luncheon keynote about the importance of data and how that is going to be playing a bigger and bigger role in people's lives. And I think the goal is really to not only have it support sort of major decisions, strategic planning, legislative and regulatory initiatives, but really help everyone in their day-to-day life and how to incorporate that data in a way that really, when you think about it, the healthcare system, it's almost like a windshield full of fog, right, for all of us. And how can data really be the defroster that allows you to see and help you make decisions? And so there are researchers right now that combine our data with other data sources, but consumers, what we try to do is really innovate at the consumer level to provide them a user-friendly outlet. And I see going forward, there are going to be ways in which to create almost online diaries that they can track what their services have been, marrying it with clinical data. That's really the ultimate goal. Right now, one of the more exciting projects that we're working on in how to use this data in a very practical way is with shared decision-making. There's a lot of interest in creating better ways in which to elicit informed consent from patients. But if there are multiple choices, clinical pathways you can go down, if you don't have the financial components of those different choices, you're only seeing half the side of the story that you need to understand. So right now we are putting together a really exciting initiative pairing clinical decision aids with cost information that could be both made available to physicians to help advise their patients, as well as available to consumers so they can really understand what the full array of choices could be.
With United's community plan, Medicaid plan here in Washington, we're going through a behavioral health integration process this year, next year, for the foreseeable future. One of the things we're discovering is that a lot of our behavioral health data has been historically given to the state, to the regional service networks, the HOs, and just this year going forward, we're going to be discovering what that data looks like. When the Washington to national comparison was up on the screen, and it's looking like Washington had a lot of behavioral health in the adolescent age group. It was like 13% of the claims volume, and the national was 14%. And I wonder if it was a disappearance of the adult behavioral health data in Washington because it went to a different payer source that never gets to the Fair Health database. So the adolescent utilization looked actually the same, tracking national to Washington, and it was a disappearance of the adult BH data due to sort of, medical legal data flows that hide it from you. And that kind of local community data block that creates artificial differences, not my biology, your biology, but my business environment, your business environment kind of problems. How do you keep track of that, dig those out, get to the right explanation in these observational comparisons?
Let me interject also to just say, Andy, we have a really hard feedback up here, so it's very difficult to hear. We can hear, but we just can't make sense very well of the microphone. And to clarify, some of the language that Dan used, regional support networks or these behavioral health organizations are effectively the mental health carve-out, historically, largely county-based, that have been outside of the MCO risk line of business, the MCO risk, but are now increasingly carved in. That is the case in some parts of the state, rather. It is soon to be the case in the whole state by 2020. So if I think I can paraphrase some of what you said, Dan, how do you sort of integrate some of the access around mental health where that data has historically been carved out in some regions, and how do you compare apples to apples when you're using that to compare to other states, and how do you get some of that county-based or otherwise locally based data integrated into this broader claims data set?
Sure.
Let me first, Dan, is that close enough? Okay.
You got it. So first of all, just to clarify again, this is commercial data, so it's not Medicaid data that we're working with. And what we do, and it's a really great question because we're often asked, one, it's important for us to take out the noise. It's important for us to take out items that could really create anomalous results or skew the data in a way. So we're always normalizing the data to make sure that we're looking apples to apples. And what we're doing is keeping consistent certain contribution lines, the spigot that flows from different contributors, making sure we're accounting for any changes in the number of covered lives that we're looking at. And so that we're able to track trends that are not impacted by a new contributor coming online to Fair Health, so we can keep things stable. We do get data from some of the specialty plans involved in behavioral health, but a number of the commercial plans give us all of their behavioral health data, so we're able to really have a complete universe from their plan designs.
Yeah, good. I'm going to interject, since we're just about out of time, to say first, thank you for coming all the way out and for doing this. I appreciate it. Will you be able to stick around for a minute to maybe answer Dan's question more directly?
Absolutely.
Or other people who have questions?
Absolutely.
Thank you, Robin. So let's give Robin a round of applause. Thank her for being here with us.